Delighted to welcome Annie Irvine to our Lunch and Learn session. Annie is a lecturer in social policy at the University of York, and she's going to talk to us today about mental health and the welfare system.
The invitation to present. So I'm Annie. I'm a lecturer in social policy at the University of York School for Business and Society, but the lecturer title is still very new to me. So I've been a researcher for about 20 years, only recently acquired the student-facing role. So I've for many years worked in applied social policy research, centering around the themes of work, the welfare system in the UK, and mental health and sort of health and disability more broadly. So what I'm going to present today, the sort of core findings of a recent study that I've worked on, but I'll just start with a few acknowledgements and a bit of context to the study. So the project was funded by the Economic and Social Research Council under its Secondary Data Analysis Initiative. So this was a qualitative secondary analysis study, which I'll explain a bit about. We drew for our secondary analysis on a very large and a sort of exceptionally large archive of qualitative longitudinal material. From the original study was called the Welfare Conditionality Project, or WellCond for short. That was also funded by the Economic and Social Research Council. But those researchers very generously archived their entire data set, which is amounts to over 1,000 qualitative interview transcripts, which are now available through the appropriate procedures for reanalysis by other social researchers. So that's what we did. When I started the project, I was employed at King's at the Centre for Society and Mental Health. So began the project with the team there, myself, Cassandra Lovelock, and then collaborators at the Policy Institute, Gabriel Lawson, Alex Pollitt, who I think is a member of this group, and Karen Glazer. So to acknowledge that the wider team, the funder, and the researchers who generated the data in the first place. We've published the study as a research report and as an academic article, both of which are open access. So moving on to what this project is and why we did it. The intention behind our study, which was about people's experience of mental health within the UK welfare system, was to try and move forward understanding of why the welfare system in this country is working so relatively badly for people with experience of mental health problems. So we know from lots of previous research that the welfare system is particularly distressing, particularly dysfunctional for people who are living with mental distress. And also welfare to work interventions that have been designed and delivered and contracted by DWP have often proved less effective for this subgroup of claimants who are claiming due to mental health. So in this project, we wanted to use a relatively novel method and to look in a slightly different way to see if we could shed any more light on why the system works so badly. And we wanted to do that by looking in closer detail at people's own interpretations of their lived experience of distress, how they made sense of their mental health problems, what they saw as the causes and the effects, and to see if that could tell us anything additional to move forward our understanding of this problem of mental health and how it interacts with the UK welfare system. So to explain the research method, to begin with, as I said, we had access to the WellCond archive, which is over 1,000 longitudinal interviews. There were nearly 500 participants in the study, most of whom were interviewed 3 times over a period 2014 to 2017. The focus of that original project was actually on people's experience of sanctions and support in the welfare system. So this is why sort of secondary analysis is quite interesting. So mental health wasn't actually a focus of the original study. And although there were a lot of participants who were sampled for different demographic and different sort of experience, different contexts around disability, around being a lone parent, around being a job seeker, a new universal credit recipient at that time, they didn't actually have a specific focus on mental health as a lived experience. But what they found was a large proportion of people in the sample talked about mental health problems. So around sort of just over 200 out of that 481. And the research team, who I knew their work and was able to have conversations with them as we thought about this project, they said they were aware that there was a huge amount of rich material in there around mental health that they hadn't had chance to look at within the confines of their original study. And so they were very much in support of a new team of researchers going in with a somewhat new question to see what could be learned from the archive. So what we did was the method called qualitative secondary analysis. We sampled from the archive 70 cases that we thought could tell us, could answer our new research question. So just a couple of quotes about the method of qualitative secondary analysis. I won't go into the ins and outs of that, but essentially it's as it sounds. It's going to existing data, but to look at an issue that wasn't kind of a focus of the original project, or asking a new question of the data that leads us to different interpretations or draws on different threads in that data, not undermining or questioning the original analysis, but looking at the data in a different way, to maximise what can be learned and to look at it from a new angle. How we drew our sample then, so I said we based our secondary analysis on 70 cases. We imported the whole of that archive, all 1,000 and odd transcripts, into NVivo to do a keyword search to find out where mental health was being talked about in most detail and in most depth within that sample. So we used this series of keywords relating to various experiences, diagnostic categories, labels that we might use, to find out which participants were talking about this and to what extent. And we use actually a sort of quantitative method of identifying those cases. So basically who used these words and who used it the most. And we worked through the cases from the person who used those terms the most, and went down through the data. We obviously looked at each case, was making sure that they were actually talking about their own experience, not a friend or a neighbour or a cousin, which we sometimes discovered the story wasn't about them. But that's how we built our sample. Where were people using these words? Where were they relaying their lived experience? And then we went into depth with those cases where there was the most rich data to draw on. So our sample of 70 was 37 women and 33 men, and despite our primary sampling was about sort of density of data, we did try and ensure a balance of gender, a spread of age range. There weren't a huge number of minority ethnic participants in the data, so we were kind of limited by that. But around, I think there were 11 participants that identified from those 70 as minority ethnic status. And then what we did was we constructed a detailed case narrative for each participant. So we read through the transcripts, and then myself and Cassie, who was my co-researcher, we sort of tried to get the chronology mapped out. So as you'll be aware, if you've done qualitative research, sometimes the chronology isn't spoken in sort of time order. So we got really immersed in the data. We drew up these detailed narratives that tried to understand each step along the journey that people talked about, and then built on that with the 3 waves of interviews, and pulled out all of the context of things that were happening in people's lives around housing, around maybe involvement with criminal justice, around caring, relationship changes, as well as mental health, and obviously as well as employment and journeys in and out of the welfare system. Our original plan with the study was that we were going to use something called the illness representational model to really get into the nuance and the language of how people talked about mental health, and then see if we could build a sort of typology of different interpretations of distress, thinking about medical models, social models, this kind of thing, and then see if those different types had any correlation or bearing on how people experienced the work capability assessment and their interactions with the DWP. So that was what was in our proposal, that we'd use this model to map people's self-understandings and see if one or other maybe shaped how negative or less negative that experience was. What we actually found, although we did do that, we did do the illness representational model analysis on everybody's story, that wasn't actually the most interesting or informative thing that we were seeing. And we actually kind of pivoted in our analysis, which I think can happen in secondary analysis because you're not sure what you're going to find. We ended up refocusing on these stories that people were relaying about what was shaping their capacity for work. And that's where our academic paper really landed, in terms of all the different things people talked about that were shaping and constraining their capacity for work, which included, but really in the majority of cases went far beyond mental health on its own. So just before I jump into the findings then and what we pulled out of that analysis, so I think anybody who's come along to this particular lunchtime seminar probably is well aware of the trends that we're seeing in health-related economic inactivity and why that's of concern to policy at the moment. And I think while on the one hand, the data that we looked at could be argued to be relatively old at the moment, it was the data collection finished just under 10 years ago, and things the structures within the benefit system in terms of the types of benefit were quite different then. This was only just at the beginnings of the rollout of universal credit. I think we can probably agree that the issue of mental health related economic inactivity has only grown over that time. So we do think this data has something important and relevant to say. And our analysis has tried to come at it from maybe a different angle than the more dominant narratives that are circulating at the moment, and the predominance that's been given to the sort of mental health crisis in economic inactivity. But what I'd like you to think about sort of at the back of your mind as I go through the findings is this question of, how do we know we have a problem of mental health related economic inactivity or health related more broadly? So we see graphs like this, which you're probably familiar with. So we've got the labour force survey or the ONS surveys, which show growth in people giving the reason of long-term sickness for the reasons behind economic inactivity. And in the universal credit data, we've got growing numbers of people in the limited capability for work-related activity group, the sort of blue section on this. So we statistically we're seeing this growth in this sort of health-related problem, this mental health crisis. But yeah, I'll come back to the end thinking about what are these statistics telling us and what really lies beneath them. What I'll say now, just before I move on to our findings, which I always emphasise, is none of the things that we say when presenting this work and in our thinking is to undermine the reality of people's distress. People's mental distress is very, very real, at times very severe and at times very debilitating, sometimes an absolute barrier to work. So that is not in question. We in no means sort of aligning ourselves with the over-medicalisation of distress debate that's circling. That's an interesting but separate question from our analysis. But the point that we want to make is that mental health, as real as it is, doesn't tell the whole story of people's economic inactivity and the challenges and barriers they're facing. It's much more complex than this, and we think this is something that needs to have much more centrality in the policy debate, to putting mental health into the context of people's wider lives and that wider set of barriers. So finally, to get on to our main findings, to cut to the chase, this is the 4-dimension sort of categorisation, the 4 dimensions of factors which people in the Wellcome data, the 70 people that we looked at their cases, talked about when they talked about the factors that were shaping and constraining their capacity for work. What I'll say first, as I've just mentioned, people did talk about the symptoms of distress. So that top left segment, that dimension of symptoms of distress and functional implications was absolutely there in people's stories. And as I said, we're by no means trying to feed into this over-medicalisation debate. So people talked about those emotional and physical symptoms and bodily experiences that come with anxiety and depression or psychosis. They talked about the social and interactional effects that has in terms of not feeling able to interact either in formal settings such as job centres or in informal with family and friends, about the difficulties in just kind of keeping the house, getting up, getting dressed, those kind of things which are impediments to that kind of work function. Some people interestingly talked about reliability and consistency in terms of capacity for work, and this was very much their own sort of self-imposed like work ethic. So they felt if they couldn't be reliable, then they weren't able to offer themselves to an employer at that time. They didn't want to be the member of staff that wasn't there consistently. So people were placing that on themselves as a sort of subtly different issue from any employer attitudes. And then obviously there were sort of knock-on effects on confidence and self-esteem and that feeling of cognitive overwhelm that can come with the factors that are contributing to anxiety and depression. So that was definitely there. But then we have these other 3 dimensions that came out of our sort of thematic analysis that people also talked about with equal prominence, sometimes with greater prominence as a factor in their capacity than the mental health issue itself. So on the top right, we've got person, environment, fit. So people often talked about their aspirations, their role preferences, the fit of a job with their prior experience and skills. They talk about the hours and the pattern of work that was going to be compatible with their wider life. And again, that wasn't only compatible with health issues, it was caring, it was other responsibilities that they had, other priorities in their life. And they talked about the right kind of work environment for them, the right kind of contractual relationship with some people much preferring self-employment for various reasons. And then just practicalities of, where was the job? Could they get to it with the means of transport available to them? Were there these kind of jobs where they lived? So that was a big factor. Moving to the bottom left, we've then got this huge list of wider personal circumstances, which are really critical to whether people felt that they were in a position to be able to get into and stay in work. And I won't read through the whole list, but some key ones that came up again and again were around housing, homelessness, and the ways that can be a real barrier to work. A horrendous number of stories of violence and abuse, of which I'll give a couple of case examples, but the way that domestic violence can really derail particularly women's careers, and put practical and emotional barriers up to that. Sort of education and training also, so people with goals and aspirations but finding that there were blocks in terms of adult education provision, and then other things around sort of perceived employer age discrimination, difficulties around citizenship status, so a whole range of things that were context to people's situation, so sometimes interlinked with mental distress, but really things that needed to be treated in their own right in terms of barriers to work. And then lastly, in the bottom right, we had sort of factors beyond the individual. And I think these really need to be kept in frame in a policy sense, the sort of structural barriers to work, which could affect anybody. So the financial viability, the benefit trap, the nature of vacancies in an area, the labour market, and then practicalities of things like transport-related issues, infrastructure, that could be a critical issue in whether people could get to the jobs that were suitable and available. So all of these things we found in people's narratives were really working together in very complex, interwoven ways to shape their self-perception of whether they were able and in a position to engage in job search and engage in the labour market. I'll just really briefly talk through a couple of case studies just to give you a sense of the sort of people behind these diagrams. Hopefully that's the font's got a bit crushed, but hopefully you can see it. So this was a participant who we called Marta as a pseudonym. Marta was a female in her early 40s. She'd migrated to the UK 6 years before the first research interview that she took part in. And in that interview, she explained that she held a professional qualification from overseas. And when she'd first come to the UK, she had a job lined up to go into. But for circumstances that she didn't quite articulate in the interview itself, that job fell through and she had to quite quickly claim asylum seeker status, and wasn't able to work in the UK initially. She then met a partner and they had a child, but this was one of, again, sort of horrendous and horrific number of cases of domestic abuse. That relationship ended quite quickly due to physical and financial abuse. So she then found herself a lone parent in the UK with this qualifications from overseas, but not currently able to work. During the time her child was preschool, she was engaged in a number of very proactive steps to try and gain UK-based experience, to try and work back towards being able to do her trained role in the UK, and she talks about a number of things that she was doing, but at the same time a number of things that were also constraints on the kind of work she could do. So there were things like the appointments that she had with the safeguarding and child protection around that situation with the ex-partner. They had, both her and her child had kind of counselling and social work appointments, which meant her availability for work wasn't 100%. She didn't have a UK licence and said she couldn't afford to run a vehicle anyway, which was an impediment to certain jobs where you need your own transport. She was caught in this bind between employers seeing her as overqualified in some senses, but then also not having the references and the recent experience to practice in her profession. But she said that some employers were seeing her CV and thinking, oh, she'll leave at the drop of a hat because she's overqualified. So she was caught in this bind, and also talks about seeing her professional skills becoming more and more dated as the years went on. She talks about the anxiety, stress and depression. As I've said, it was very much a part of it. But you can see from the way we've mapped it here, it was one strand and an interwoven strand of many other factors that were playing a part in whether she felt able to work and the kind of work she could do. And Marta was interesting because she herself was very keen not to medicalise her situation. But what happened was when her child reached school age and she moved from income support into the job seekers category, at this point when the research was done, that was the child being age 5, it was actually the professionals around her who sort of mobilised that move into a health-related benefit. So she said her son turned 5, so she went on to job seekers. But then the social services said, she needed to stay home, and initiated with her GP a sort of SIP note that meant she moved from job seekers allowance onto employment and support allowance and became a member of this category, a member of this curve that we're seeing in the health-related benefits. But as I said, she maintained, whilst acknowledging the difficulties she was having with anxiety and depression, that she needed practical support for work. She knew what she wanted to do. She was taking those steps, and she said, you know, the doctor put me on antidepressants, and she sometimes was attending counselling, but it wasn't going to help her in the employment sense because she knew what had happened to her. She knew how to move on, and she needed practical support around employment. One other case really quickly, Kyra was another participant whose work life had been thrown off track by the impacts of domestic abuse. She'd become a lone parent and was looking to find work that was compatible with her child's school hours. And to that end, she'd started training as a teaching assistant. But again, when her son reached school age and she was moved on to job seekers allowance, she was mandated to go onto the work programme that was in place at that time, which clashed with the teacher training she was doing, and put at risk all of the work she'd done. She was quite close to finishing that at this point, but was told by the job centre she had to go on the work programme, and there was nothing that could be done. And so she was put in this horrible situation of taking very sensible, proactive, committed steps towards a career that would see her financially independent. It was a stable job, and an obstacle was placed up to that by moving on to job seekers and having to do this mandatory work programme. It's quite a long quote here, but in essence, she was, as I said, she spoke to the job centre advisor, explained that she felt it was unfair and she was going to have to forfeit the work she'd done towards the teaching assistant qualification, was told there's nothing that the job centre advisor could do, she'd have to do it. She then spoke to her domestic abuse support worker and, you know, expressed the distress she was having about this. And the support worker suggested, ring the doctor, go to the GP, get signed off. And that's how she, again, found her way from job seekers allowance, actively seeking work, into the economic inactivity category of then ESA. And she said, you know, that's why I got signed off onto ESA, because she was so depressed that she wouldn't be able to finish the course. And thus she becomes another member of this group that we see in that rising curve. Again, you know, I think this is a very telling quote from Kyra, that she didn't want to not work. She didn't necessarily see herself as unable to work, but she just needed that breathing space to finish the course, and sort of to alleviate her from having to do the mandatory work programme, which, as she said, felt completely unnecessary in her view, because she had a plan and she had a career on the horizon. So if we go back to the different dimensions of factors that are shaping and constraining people's capacity for work, in terms of a policy implication, what we draw from this is that the way the system itself is designed at the moment, it's almost kind of creating, in part, a self-fulfilling prophecy of so many health-related claims, because it's really the only way that people can explain these complex stories. When it comes to the work capability assessment, so there's sort of two things that we've sort of argued in the paper. The work capability assessment, which is the way of determining capacity for work, only looks at this part of the picture, that the ESA 50, the UC 50, it only asks about health. And so those are the only things that people can talk about when their capacity for work is being assessed. So really, you know, it's designed in a way that separates the mental health or the health from the whole rest of this bigger picture of factors that also constrain people's capacity for work or limit their opportunities to be economically inactive. And everything has to be squeezed into this one part of their story, because there's nowhere else for it to go. In the current system, health is the only legitimate or legitimised part of people's stories, and it is a part of the story, but it's the only part the system really has ears for, is the sort of argument we want to make, despite there being this whole other interwoven set of barriers to work. But then I think the second mechanism, which is exemplified in the two case stories that I've given you, and there are several others, and we're going to work on another paper that sort of makes this point more explicitly, is that when things reach a certain point of crisis or a certain level of intensity, and then particularly when conditionality enters the picture, that can be the trigger for people to move from that economically inactive job seeking, preparing for work, into the health related economic inactivity status. And it's because these constraints of the system and the threats of sanctions and the threats of having your money taken away if you don't do the things you're being mandated to do, whether or not they fit with your own kind of game plan and sensible strategies around work. Again, this is where the breathing space is, as Kyra said. This is the only part of the current system where that pressure and that threat is alleviated. And again, this is not people fabricating or making up or exaggerating, but it's the design of the system that has to move all of this complexity into that space when the system closes in on people and starts to feel even more threatening. So just to sum up then the sort of 2 key takeaways, I've only just really said this, but our sort of key takeaways are that representing economic inactivity as a problem of mental ill health or health more broadly only offers us a partial understanding of why people are unable to work, and importantly of what support they need to move closer. And I think one of the possible counterproductive effects is that when health and mental health are so dominant in that picture of factors shaping capacity for work, rightfully so, but a huge amount of focus then gets placed on mental health support, that kind of narrow understanding. And actually, as many participants showed in their stories, there's a whole gamut of holistic support that people need across a range of aspects of their life, as well as direct sort of clinical intervention. And then the other point, again, is, as I've said, when things reach a critical mass of complexity, health becomes the only part of people's stories that the system will hear. And I think that's where we see this slightly self-fulfilling prophecy that people are forced by the system's design to move into that health-related space to find the essential stability and breathing space that they need, from things that feel to them inappropriate and threatening. Just want to leave enough time for questions and answers, so I'll skip very quickly through the last couple of slides. Just to come back to this graph and just to make that point that although these are the sort of quantitative statistics we see, the qualitative evidence shows that beneath this curve, every single data point on these graphs are a complex individual life with much more going on than the headline of their reason being long-term sickness or incapacity for work. There's many dimensions to each of those stories, and so this gives us a trend which arises from the kind of questions that are in surveys, but there's a lot more to it, and people have to find the best fit within the categories, a best fit and a fit which the system will legitimise and take seriously and take as valid. But there's just a lot more to everybody's story than these categories really allow. So yeah, my last slide is just a summary really of the main points. I maybe won't read them again, and I'm very happy to share the slides. But in terms of what we recommend is a much more holistic and less punitive approach to welfare to work, because this would have the 2 benefits. We sort of hypothesise it could reduce these kind of system-driven health claims where everything has to fall into that bucket of health, which then kind of masks or drowns out the other factors that people need support with. And if we had all of those range of factors on our diagram much more to the fore, much more to the surface, given equal weight and prominence, we may be able to improve the way that people are supported towards work in much more holistic ways, which is happening in sort of third sector. There's amazing work being done. But yeah, brings all of those other factors back into the picture so that people get appropriate and holistic support towards work. So that was all I had for presenting. Some of the key references I was happy to share via Barbara. Yeah, so really happy to have any feedback or questions or reflections on that.
Annie, thank you so much. That was